Colleagues, ladies and gentlemen, as mentioned, my name is Dr. Etukoit Michael. I'm the Executive Director of TASO. TASO is actually the earliest organized civil society response to HIV in Uganda. So I'm going to talk about differentiated models of service delivery. Uganda as a country, we're moving towards test and start. You test for HIV, and if you're positive, you start the treatment. And because of that, there will certainly be an increasing number of clients, of people who will need ART. Given in the context of a GDP per capita of about $700 and then a health expenditure of about $59 annually. You have varying levels of support and models based on client needs. So these are imperatives for differentiated models. You have a very low GDP per capita, very low health expenditure per capita. You have an increasing number of people who need ARVs. You have people who are very poor, cannot afford to come and collect their drugs from the health facilities. You have to provide services for adolescent girls and young women separate from adults at their clinics. You have a largely illiterate rural population. So those provide the imperatives for differentiating service provision. We also have different types of providers. They range from certified health workers, that's doctors, clinical officers, and nurses. And then we have the other trained lay health workers, which will range from members of the communities, ordinary members of the community, civil leaders, political leaders, opinion leaders. You have expert clients, people who have been on treatment for a long time. And then you have a whole host of other many types of volunteers. But these models, as mentioned by Mark, largely hinge on an effective community platform. Involvement of the communities, people who are HIV positive, their family members, their relatives, their friends, and other various government departments. Of course, the benefits of community, there are a lot of benefits for community engagement. It provides you platforms for other interventions. You organize a community, you capacitate them because you provide capacity building for these communities. That slide just shows the types of services we provide. The red ones are specific services, is one of the remote and the least developed part. The red dots, the least developed parts of the country. The black icons of women, those are programs specifically in districts targeting adolescent girls and young women. And then the triangles are comprehensive district-based programs working with the Ministry of Health. And then the black stars are the centers of excellence and then our head office. So this is just a sample of a differentiated model of service provision, and this is for HIV testing. We have a home-based HIV counseling and testing, which targets families of the index clients. People who are HIV positive as the index client, we follow them up to their homes to provide testing for family members, especially the spouses, and the children, especially those below 5 years who are likely to be HIV positive. And then there are customized integrated HIV testing outreaches and to hotspots targeting key populations, men who have sex with men, sex workers, among others, and fisher folk. And then you have mass community campaigns such as Family Health Days, and then you have the integrated HIV testing and counseling. So the other very prominent differentiated model is to do with the delivery of antiretroviral drugs against the context which I've mentioned earlier on. As an organization, we have about 100,000 clients, active HIV positive people. 70% of these receive their care within the communities and in their own families. They don't get this support, this care from the health facilities, as I had mentioned, the reasons I mentioned. So the major approaches include providing drugs at the community. You take the drugs at the community, at agreed locations you agree with them. They decide where to provide the drugs. This location could be, it can be a health center, it could be a school, it could be a home of one of the clients or a community leader, it could be a church, a mosque, or whichever location is agreed. So the drugs are taken there, then registered clients for that point come and receive them at that point. So there are so many of them. There are over 700 at our various service delivery points. But as we're doing that, as we continued, the number of people who needed drugs kept increasing. It was no longer possible to do that because those points had grown into very huge units. So we had to find a way of breaking them down. So we differentiated into by involving clients, people who are HIV positive, who are experts, to come and receive drugs at those points and go and distribute them to their colleagues in the communities. So that is the community client-led ART distribution. We also established drug distribution points at the facilities where people just come to receive only their drugs. They don't have to interact with a pharmacist or a clinician unless they need to. We started by providing 1 monthly refills. At the beginning, we're giving 2 weeks, moved to 1 month, to 2 months, and to 3 month refills. So the quality of programs, as mentioned, it is a rights-based approach to service delivery. We have a lot of collaborative approach to quality improvement with the Ministry of Health, with the CDC, with the USAID, and many other technical agencies. We do capacity building for quality improvement teams. At district level, there are QI teams, and then there are also QI teams at the health facilities. So these are capacitated, trained to provide quality improvement. Each of the sites has a QI team with all what they need to provide QI, standard operating procedures, policies, and guidelines, and use of data and a dashboard to improve program dashboards that capture the indicators, they capture the targets that need to be achieved in relation to quality improvement. And then QI models that apply the interactive plan, do, study, and act. And then regular performance reviews. We conduct client exit interviews to get input into the quality of the programs. We conduct medical audits and spot checks by a variety of technical people. In relation to efficiencies, by 2012, the cost of providing ART was United States $322. And this was lower than previous analysis conducted among 5 PEPFAR countries in Botswana, in Ethiopia, Nigeria, Uganda, and Vietnam in 2008 and 2009 because of application of differentiated service delivery models. Of course, we shall need, as it will be elaborated, additional support, more support in terms of looking in detail into these models and really identifying those that are working and how efficient and effective they are. As an institution, as an organization, 90% of our clients in care are currently on treatment. Thank you.